Good evening, everyone. Today we'll be talking on ADHD. ADHD obviously is an area which concerns everyone, particularly students. And Professor Sagar and the child guidance team has done exceptional and enormous amount of work in this area. And I'll be requesting Professor Sagar to take the lead in presenting. I'm happy to inform you that Professor Sagar has recently been awarded honorary PhD from the NIMS University in Jaipur. So this is also congratulating you.
So good evening, everyone. It's wonderful to be here, and we'll be talking about ADHD. Now, the question is that why we have taken this topic. Our department has a long history of child psychiatry clinic, child guidance clinic for almost more than 60 years now, and it is one of the oldest, if not the oldest. And so when we talk of problems, behavior problem in children, then it is one of the common problem. And in that group, the behavioral problem, the ADHD is very, very important condition. So, so this particular discussion today is on ADHD. So this is the outline. We have a team of all faculty here. I will be talking on introduction, impact, burden, diagnosis, assessment, Dr. Renu Sharma. Then Dr. Bichitra Patra will talk about comorbidities and pharmacological management. Then Dr. Rachna will speak on cognitive symptoms, psychosocial factors, and intervention, psychosocial intervention. Then Dr. Simran from Additional Professor Department of Physiology, she will be talking about physiological parameters and ongoing projects with Dr. Renu will talk about. Then finally, I will talk on the research initiative. So just to briefly talk about, I think many of you will know, it's a cluster of three kinds of symptoms: hyperactivity, impulsivity, and inattention. And it's one of the commonly diagnosed condition as a behavioral disorder, like 5% of children and overall 2.5 adults worldwide. So one can see that it's quite common. And the problem is that these children have a pronounced difficulty and impairments, which we'll talk about later, in different spheres of life. That is academic, vocational, social, emotional, and peer relation. And of course, it has a significant burden on individual, family, and the community. And the important is that it's a heterogeneous condition and it has a long-term effect on children and later life. So what it means that the ADHD needs a proper assessment, diagnosis, and the management becomes very crucial and very important. Now, what's the importance of ADHD and what's the impact? Why we need to know about ADHD? Now, if you see, maybe slightly older, but this gives a glimpse of what the impact of ADHD can be. Like, and these are all evidence-based, like all the researches references are there. Like one is the healthcare system, 50% increase in the bike accident, and then almost 1/3 increase in the emergency room visit, and 2 to 4 times more common are the motor vehicle crashes. So just imagine that the kind of impact it has on the healthcare system. Then family, of course, there are many evidences to say that 3 to 5% increase in the parental divorce. In fact, that again is a very, very important aspect, because many times we have seen in medical board and all where, the burden to the family is so huge, even to the extent of parental divorce or separation or sibling fights. Then school and occupation, again, the child is affected tremendously, like 46% expelled from the school because of number of reasons like behavioral problems, academic problem, and so on. 35% the dropout, lower socio-occupational status. Society, again, which again is a very important when we link with ADHD and substance use disorder, 2 times more risk is there. Early onset, not only the risk, but also early onset, and less likely to quit in the adulthood. So one can imagine that how much impact it has. And the employer also increased parental absenteeism because they have to take care of a child at home. So there is absenteeism from the office and work, and also reduced productivity. So one can see that the impact is tremendous of untreated and undertreated ADHD. Now, these are all the evidence to suggest that the problems or the negative impact which can have in the personal life, that is problems at the life at school, almost 45%, problems with the daily life and the activity, social life, life at home, relationship with the friends, relationship with the siblings, and relationship with the parents. So there is a negative impact, when we talk of ADHD and its negative impact on the self. Now, also we need to see that other than the negative impact on child, there is also a problem related to caregivers, problem with the scholastic performance, we all know in our clinical practice, and also problem with the peer relationship. And there is a lowering of self-esteem because person with the child with ADHD, which is externalizing disorder, ADHD conduct, can also have a anxiety, depression. So some of the lower self-esteem can also occur together. And it's frequently comorbid with the psychiatric and not only psychiatric illness, but also medical illnesses. Now, this is something worrying and very important. You can see that twofold increase in the premature deaths at the age of 46 years. So based on the longitudinal cohort studies. So one can imagine that the impact is so huge and significant increased mortality rate. And when they are comorbid with some of the other conditions like oppositional defiant disorder, conduct disorder, substance use disorder, then there is again increased mortality further, more than if it is alone. And so in spite of all the factors, ADHD is the one condition which leads to excessive mortality. And one of the important reasons is that because of unnatural causes like accidents, and they are the factor which lead to increased mortality. Now, just to give you a glimpse, the evolving concept of ADHD, like George Still described more than 100 years ago, 41 children with restless, impulsive, inattentive problem. They were predominantly described as a defect of a moral control, and basically was again, in a way, thought the problems with there is the underlying neurological deficiency, which again was reworded in the sense that it was said that it is a more of a problem with attention and impulsivity instead of moral and religious. So it was a more of a in the medical paradigm. Then again, we all are aware of influenza pandemic which happened, which again led to a lot of behavioral problem. Recently also we had a pandemic, so we don't know what will happen in the future. But if you see 100 years ago, so it has an impact on increase in the ADHD symptoms. Then the concept of minimal brain damage came up, like organic brain damage, but many studies were not able to prove that damage was there, so the term was changed to dysfunction. That is a minimal brain dysfunction. So many times it was written as a MBD, a minimal brain dysfunction. Then the concept of hyperkinetic disorder also came up, like in ICD-9, ICD-10, the concept of hyperkinetic disorder was there. Started in the ICD-9, DSM-2, then which was less stigmatizing, but the term was very much there, hyperkinetic syndrome of childhood. Then there was important concept when we talk of, in fact, hyperactivity was not included in that. It was only known as attention deficit disorder with or without hyperactivity. That in the 70s this concept came. But again in DSM-3R it was called as a ADHD, irrespective. So ADD along with hyperactivity symptom. And the current is, of course, we talk of lifespan, like even in the older adults, we can make a diagnosis of more of a neurodevelopmental condition. Now, what's the burden? Just quickly going through, it's a huge, in the sense prevalent, like some of the pooled prevalence figures are 5%, which with significant heterogeneity. In India also, the review article which was published some time back, from India studies itself, it came as a 4.7 to 29%. DSM-4 slightly overdiagnosed because of many reasons. And of course, one of the important factors is when the functional impairment is taken into consideration, obviously the prevalence goes down. Now, this is a Lancet study for 12 mental disorder, including ADHD, and you can see that it's 1.1%, 1131 out of 1 lakh population. So you can see, but the important thing to see here is South Asian countries. If you see that it's much more, as compared to other countries. So again, we need to be aware of this. Then our own burden of disease published paper, which again talks about different condition, including ADHD, the prevalence 0.4%, more in males, and the variation was there in different states of 2.8 times in different states. Then one can see that in this, the important thing here is that age of 10 to 14 years, it's a peak. That's a peak. Then later it goes down, which again as per the article. Now, from our own data, which we presented some time back, it is around 18%, 1 in 5. One can say that those who come to our OPD, those who seek help in our clinic, so it's almost 1 in 5. Now the point is why early diagnosis is important, because always we say early identification, and because one of the important thing is that the continuity of ADHD symptom can be there in the impairment, can exist in adulthood, and 15% of them may persist in the adulthood, whereas 40 to 60% may have a partial symptom may be there in adulthood. So this is something new which has come even in adult. This is the important concept, and some of the symptoms which are there in childhood can persist later in the life also. The cost is huge. I'm giving that some countries have estimated the cost of that is why the need for early diagnosis is there. Also, it can lead to stigmatization. I think that also is very, very important, especially a child who is going to school, the way they are labeled, the way the stigma occurs. I think that also has an important implication. That is why there is a need for early identification. Now, before I talk of diagnosis, I think if you can see that many times we have seen that child who is easily distracted, unable to follow tasks, refuse to follow the governed rules, and fail to comply, get restless easily. But we try to give a label of ADHD, but at the same time we know that this could be there because of these reasons also, like boring lecture, bodily symptoms. So a child may be hyperactive for all these reasons. So that is why it is important how to make a diagnosis of ADHD. Now, assessment, again, Dr. Renu will talk about. We have DSM diagnosis, very clear-cut, like persistent pattern, inattention and hyperactivity and impulsivity symptom. Basically, there are two groups of symptoms, and like 9 symptoms are there in inattention and 9 symptoms overall in the hyperactivity and inattention, out of which 6 should be present to make a diagnosis. And also here in DSM, it's important, even a person who do not have a hyperactivity symptom, still you can make a diagnosis, though the term is ADHD. But still, even if there is only inattention symptom, one can make a diagnosis of ADHD. And other than that, these are all symptoms where age of 17 and more, instead of 6, you only need 5 symptoms. Again, there are some modification because, and symptom has to be there before the age of 12 years. Earlier it was 7 years, now in the DSM-5 it is 12 years. Then it has to be more than one setting, like at least minimum it should be there, symptoms should be there in the 2 settings. Now these are different symptoms of inattention. I will not go into detail. Basically, it's a careless mistake, difficulty in sustaining attention, and does not seem to listen when spoken directly, does not follow through the instruction, difficulty in organizing tasks, and so on. So easily distracted. So these are the symptoms, and out of which 6 should be present to make a diagnosis of ADHD. And these are the group of hyperactivity and impulsivity, basically fidgety, on the go, restless, all these symptoms which are there, talking excessively, cannot sit still, and so on. Other than this, the important thing is in psychiatry diagnosis is that interfere with the social, school, and the work functioning. And importantly, it has to be ruled out from the other psychiatric condition. These are the different presentation could be that there are different types, and these are different severity, mild, moderate, and severe. Then ICD-11 also diagnose almost same, like DSM-5, the whole set of symptoms, because in the ICD-10, the term hyperkinetic now it has been replaced like a hyperactive ADHD again. And again, here it is, the age is 12 years, so most criteria are same as the DSM-5. And again, subtypes are also same, the dysfunction also is same. Now, just to end here, the research output of the department has been there for, I am saying this for last 2 decades or so. We have number of publications, book chapters, abstracts which have been presented in national, international conferences, and whole lot of MD thesis has been there, and several research projects, funded research projects have been there. So with this, I will invite Dr. Renu to present the next part.
Thank you, sir. Good evening, everyone. I'll be briefly talking about the psychological assessment of ADHD children. So assessment is very, very important for any kind of disorder, and similarly, it is for ADHD. Here in psychiatry, we have specific structured psychological tools which are objective in nature, with the help of which we'll try to assess a child or an adolescent. So when we first start with assessment, typically in our clinical setting, we'll start with a comprehensive history. And that history taking is done from the family members, from the caregivers, and sometimes we'll also ask information from the teachers, because they are the one who will spend a good amount of time with children, and they can provide us very important information. Apart from this, clinical observation during the interview is very, very important, because children are like many times they are not expressive. They cannot share their own problems and their feelings. So in that sense, clinical observation and observing the things, that how are they behaving and why are they behaving in such a manner, is very, very important. And apart from this, we are having certain diagnostic tool, we are having screening tool and the checklist, with the help of which we can assess the child and we can combine that information with the observation. Now we have to understand that how can ADHD testing help us in our clinical setting. So first of all, definitely it will help us in making a diagnosis. With the help of the various diagnostics tool, we can have the diagnosis. Then it will also help us in gaining more insight about a child's strengths as well as weaknesses. Because many times it's believed that since these children are lacking in academic performance, probably they are having low intelligence, they are not good in studies. But we have seen in our clinical practice that they're having very good IQ, and they're much creative than other children. If we give them time and if we give them exposure, they'll make very creative things. Apart from this, with the help of the assessment, we can also get information about certain other problems like the working memory weakness, if they are having any difficulty in processing speed, learning difficulties if they are having, or any other kind of comorbid conditions like conduct or DDD and anxiety disorders. And further, that assessment, through assessment, we can provide valuable information to teachers where they can make necessary arrangements or adjustment at the academic level, or if they need any kind of exemption from the at the level of school. Okay, so here I'll be talking about various kinds of psychological tools, in which Inclin diagnostic tool for ADHD is one tool which has been developed by Inclin Trust. This is a tool which has been validated for an age group of 6 to 9 years of children. And then later on, this tool was refined and validated by AIIMS team in collaboration with other departments. So the good thing about this particular tool is that is validated on Indian population. It is very easy to administer, and we can have very valuable information about in case of making a diagnosis about ADHD. So these are the two related research papers which have got published. Okay. These are other tools which we can use in our clinical practice, like Corners 3 ADHD rating scale, which is a diagnostic tool which can be used, and we are using it. Another one is like Vanderbilt diagnostic rating scale. Apart from this, CBCL, which is a very, very useful tool, and we are having two forms of this, and we are having like a parent form where we'll ask information from parents, and at the same time we are also having YSR, that is the youth self-report. So for different tests, we're having different versions which will help us in getting valuable information which can be further utilized in forming or maintaining, forming the intervention for these children. So with this, I'll invite Dr. Patra to continue further from here.
Okay, thank you. I shall be discussing about the comorbidity conditions associated with ADHD and the pharmacological management before going to the psychosocial aspect. So, comorbidity means that is two or more disorders that occur at the same time. So, which is very high in case of ADHD children. And the previous study that shown 33% had one comorbid and 16% had two comorbid and 18% had three or more comorbid conditions. And risk for having more than or equal to three comorbid condition was very high in case of poor patients. So these are the some of the comorbid condition most commonly found as learning disability, then conduct disorder, anxiety disorder, depression, and speech problem. Other studies also have similar findings. Around 2/3 with current ADHD had at least one other diagnosis. Like behavioral or conduct problems were the most common, around more than 50%, and other diagnoses were anxiety, depression, autistic spectrum disorder, and Tourette syndrome. And current substance use disorder is also found in 1% of the adolescents of 12 to 17 year age. So on this, there was an MD thesis from the department way back from 1999, a study of comorbidity in children with ADHD. And other comorbidities that also found is internet addiction, which is around 56%, and increased screen time, like even younger children up to 2.5 to 6 year of age, which is much more than the recommended time. The recommended time for this age is maximum 1 hour, but this study found that around 140 minutes per day, more than 2 hour duration. And there is a positive correlation between ADHD symptoms and addictive Facebook use, past negative orientation. So on this, there was another study from department MD thesis that recently submitted for conducting the MD thesis, that is exploring social media use and its correlates in adolescents with ADHD. So the objective of the studies are to measure and compare social media use in adolescents with ADHD and compare with healthy controls, and to see correlation between social media use and response inhibition, impulsivity, and emotion regulation, which is found to be impaired in ADHD children, and it has a relationship with the social media use disorder. So, and apart from psychiatric comorbidity, this is one study from Germany, that is the a cohort study on a 5 to 14 year of age group. So which compared 800 plus physical comorbid condition and psychiatric conditions among the participant and the control group, which are matched on the age, gender, and region. So this found the most common disorder, which is much more high in the ADHD group, is the metabolic disorder, then viral pneumonia, disorder of blood cells, kidney failure, hypertension. Most of the asthma, atopic dermatitis, juvenile arthritis, and migraine. So these are more likely to be in ADHD participants than in the healthy control group. So then coming to the pharmacotherapy. So these are the two groups of medication, that is stimulants and non-stimulants. From the stimulants medication, that is methylphenidate and amphetamine. The amphetamine is not available in India. The methylphenidate from the stimulant group, we are using this, and the mechanism of action is norepinephrine dopamine reuptake inhibitor. So this increases the concentration of dopamine in the synaptic cleft, and the amphetamine also facilitates the dopamine release in addition to the reuptake inhibition. So the studies, the longitudinal study, the multimodal treatment on ADHD study that found that the immediate release methylphenidate has improvement in the ADHD symptom, and recent Cochrane review also replicated the same result. And the recent review that included 3 meta-analysis, 1 systemic review, and 10 RCTs also found that that long-acting methylphenidate is less effective than short-acting. That is, immediate release is is having more effect. And so these are the various the doses of methylphenidate and the preparation that we are using, the sustained release and the immediate release preparation. And the dose, that maximum dose of the immediate release up to 60 milligram, and the sustained release up to as per the age group 6 to 12 year 54 milligram, and 13 to 18 year maximum dose is 72 milligram. So gradually the dose is built, not at once the maximum dose is tried. And this is the separate prepared transdermal and concerta. Concerta, that is the osmotic controlled release oral delivery system. This is very costly. The advantage of this system is it 22% is immediate release, and other remaining is the osmotic release. So the advantage is that we have just discussed that the immediate release is having a better effect. So and the sustained release also sustained the effect of the medication. So, this is the newer preparation, and apart from the stimulant medication, that is atomoxetine is also used frequently. The mechanism is this is norepinephrine reuptake inhibitor. So this is also found that it causes improvement in overall ADHD symptoms, and who are drug naive, they have greater response to this. And the dose is that started 0.5 milligram per kg and gradually increased to 1.2 milligram per kg, and maximum dose is 1.4 milligram per kg. This is the meta-analysis that 48 trials that involved 4,169 participants. This showed that combined ADHD is more than the predominantly inattentive and predominantly hyperactive. So this is the order in which the response to atomoxetine is seen. And this is another trial that combined the meta-analysis, and it found that methylphenidate is the most effective than other medications. So this is some of the side effects. Most common side effect to which our Indian patients, children and mothers are sensitive is poor appetite, and that can cause decrease weight gain and height gain. So the precaution that we take, that we regularly monitor the height and weight of the patients who take this medication. So on this, that we have done recently submitted an MD thesis last year, that is neurophysiological predictors of response to methylphenidate in children and adolescents with ADHD. So the objectives of this study are to assess the role of neurophysiological markers, that is the QEEG and cortical evoked potential in predicting response to methylphenidate, and to compare the difference in the QEEG parameter and ERP parameters in good and poor responders to methylphenidate. The findings of the studies are baseline spectral power of alpha wave at occipital channel location was significantly smaller in good responders, and a significant correlation was found between theta beta ratio and baseline CPRS score, and the non-target N200 latency and target P300 latency was significantly different between good and poor responders. So other study that is going on, another MD thesis, that is prefrontal cortical activation as a neurofunctional biomarker for monitoring acute effects of treatment in children with ADHD using FNIRS during saccadic movement, which is done in the lab of Dr. Rohit Verma. So the objective of this study is to evaluate the effect of treatment on prefrontal cortical activity during saccadic eye movements in children with ADHD, and to compare prefrontal cortical activity during saccadic eye movements in children with ADHD with healthy control. So this study is going on, and this is also another MD thesis that that has completed in 2015. It was started. 2016 it was submitted, and the objectives were to assess prefrontal cortical activity during executive function tasks in children and adolescents with ADHD using FNIRS and compare with healthy control. And the findings of the study that individuals with ADHD showed evidence of hypofrontality during the performance of executive function tasks, and this paper that won the award, the poster award in the annual National Conference of Indian Psychiatric Society in 2020. So this is also another project that is going in the collaboration with Department of Physiology, the principal investigator Dr. Suman Das. This project is funded by Science and Engineering Research Board of DST, and the study is identifying early signs of ADHD in children by decoding their acoustic vocal profile. The objective of the study is to develop a user-friendly and low-cost endophenotype for ADHD children by analyzing their acoustic vocal profile. So, apart from the pharmacotherapy, that recent intervention like transcranial direct current stimulation, brain stimulation method, that has also found to be effective. And on this, we recently started a project which is funded by DST under the Cognitive Science Research Initiative scheme. The title of the study is Effect of Transcranial Direct Current Stimulation on Cognitive Function, Symptoms and Functioning in Children and Adolescents with ADHD. The aim of the study is to examine the effects of transcranial direct current stimulation in addition to the treatment as usual in children and adolescents with ADHD. Now I invite Professor Rachana Bhargava to talk about the psychosocial management in children and adolescents with ADHD.
Good evening. Thank you, Dr. Vichitra. The management for ADHD children can be done through non-pharmacological management as well as non-pharmacological management. The psychological interventions are important to deal with the psychological issues, the behavioral issues of the child, family distress, and the school disruption. In an ongoing AIIMS-funded research project, which is being done in Delhi and Chandigarh, we found that among the school-going adolescents, 20% of the children had hyperactivity, and among these hyperactive children, mild cases were significantly more. So, in mild cases, psychological interventions are more important. To understand the psychosocial issues, I would like to highlight that because of ADHD symptoms, the child may have emotional dysregulation, lack of social competency skills, they are accident prone, and also have fights with peers, teachers, and at school plays. The academic performance may be low due to not only ADHD symptoms but also associated comorbidities. As we can see from the earlier slides by Dr. Vichitra, I would like to highlight that since 2006, there have been a number of research theses related to MD, which have focused on executive functioning in the ADHD, and which have found that working memory, fluency, attention deficits are marked, and we need to deal with them in the management. So to sum up, we need to deal with the social as well as the cognitive deficits, associated with other comorbidities as well. We have to work at 3 levels: child, parent, and school. And of course, the psychoeducation is important, and it has to be addressed in view of the age of the child and the family. Most of the time, the aim is to reduce not only the symptoms, but also enhance the academic performance and reduce the distress in the family and the school environment. This slide lists the indicators on the basis of which we decide the type of techniques that we use. Psychoeducation formed the most important step towards intervention, where I would like to highlight that most of the parents refuse to take medication, and through psychoeducation, with regards to illness and the treatment course, they become more compliant, reduces their guilt, as well as the child is motivated to learn the new skills to overcome the negative outcome. So most of the time, the parents form the important source of intervention, and parent training has been an important area of intervention. As previously in 2006, there was a PhD work which involved development of the parent training module, which not only focused on developing the training techniques, but also its efficacy, and also emphasizing on the various issues that pertain to the training. As with other psychological management, assessment is integral to management. Besides clinical interview and standardized tests, functional behavioral analysis is important to understand the precursors to behavior, as well as what comes due to the problem behavior. It helps us to understand whether we need to manipulate the environment at the antecedent level or at the consequence. To understand more, I would say how ABC can be explained. If the bell rings, the child does not get up to take the maths book, and the teacher yells. Instead of yelling, if the child follows the instruction of taking out the math book, the teacher smiles. So there is a reward when there is a acceptance of the instruction. So this contingency is often used in the behavioral intervention. Another example, if the child is showing repeated anger outbursts, he is given various options. If he does, it will lead to the reward, but if he does not, the reward is not given. So the basic essence of behavior modification is reinforcement. What instruction is to be given, irrespective of the situation, that is very important and is communicated to the parents. The reward should be linked to the consequences. The reward should be linked to the behavior so that the child understands that reward is coming in which context. There, if I say that good job, so the child may not understand this praise is linked to what kind of behavior. So if he is told that the way he has solved the maths problem is good, so he knows that the praise is linked to the maths solution. So, but it is important whether the praise is has any importance to the child or not. So the reward, what is identified, is important for the parents. We have to keep in mind that the reward should be in the ratio of 4:1. And what kind of reinforcement are given, when to give the reward, that is also important to make the child keep it motivated towards pursuing the positive behavior. To give this example, if the child is wandering around in the classroom, so he can be given differential reinforcement as an alternative behavior to raise the hand, or ask him to sit, which is incompatible to the wandering around, or he's given a reward to sit longer so that he gets the reward. So which is again, it's another behavior which is alternative to the problem behavior. He can also be in the classroom setting. Specially, we often advise the teachers to use the response cost or the token economy, where the tokens are clubbed together and replaced with a reward. Activity scheduling is a very important step towards organizing the disorganized child, where we introduce different timetable, keeping in mind the interest of the child, what is doable, and also asking the parents to introduce structured games and include academics addressing the cognitive deficits. So when he is studying, he is asked, most of the time the parents usually go for marathon sessions because the child is not doing well. So they are asked to have frequent breaks and keep short-term goals. Rather than going for the full chapter, he has to identify short-term which can be completed without his getting up from the place or getting distracted. So he gets a feeling of achievement, and to prioritize which should come first, and using the mnemonics or different techniques like primacy effect, like whatever he starts first is bound to be retained later. So these are some of the exercises which are also introduced in the timetable depending on the age of the child, which helps to enhance the academic performance. In the classroom, many times there are issues with the teacher, so we coordinate with the class teacher or the counselor to allow the child to sit in the front, so that it makes him complete the classwork. He is more attentive, and besides introducing some of the usual techniques along with the teacher. Other skills like social competency is dealt with if required. With adolescents specifically, cognitive behavior therapy is used to address the negative cognitions which come up because of the poor self-esteem, where he now understands that he is not able to perform as well as his other sibling or other peers. Mindfulness-based intervention is often used. Recently, a PhD scholar has taken up this development of module with adolescents in ADHD. There are plethora of articles, systematic reviews, meta-analysis, which have compared different types of interventions and have recommended different level of evidence with different age groups, moderate to high evidence for behavior therapy for mild cases, but for the severe cases, combined medications as well as the behavioral interventions are recommended. One has to have a holistic outlook for dealing with the skill deficits, and CBT definitely is recommended with adolescents. Mindfulness based intervention, which has been recently been used but has been recommended for parents and adolescents. Although this sounds easy, behavioral interventions, since they are recommended, they are easy to implement, but at the same time, we often face challenges while training the parents, because though they pick up the techniques, but there is problem with the implementation. Thank you. I would now like to request Dr. Simran, Additional Professor, Department of Physiology.
Thank you so much for your kind words. It's a pleasure to be there. So I'll be discussing on the physiological parameters in ADHD, particularly focusing on quantitative EEG as a state and trait marker in ADHD. So just keeping a light on our collaborative work with Department of Psychiatry in terms of ADHD, an article on non-invasive measure of brain iron in ADHD led to the inquisitiveness, and with that we started our first project in order to study the cortical sources of EEG and brain iron levels during rest and working memory in ADHD. So this was funded by DHR, and this work was further being carried out as a PhD thesis by Mr. Ankit. Further, dwelling more into the ADHD scenario, so we plan to study the QEEG-based neural correlates and microstates of attention and interference in ADHD and an endophenotypic marker. So again, this work was being carried out by Chaitanya, who recently submitted her PhD thesis. So my presentation today will particularly focus on the data which has stemmed out of these two theses. I was fortunate to collaborate as a part of MD thesis with Dr. Bichitra and Dr. Sagar regarding the neurophysiological predictors of response to methylphenidate in children and adolescents with ADHD, the work which has been submitted by Merlin. So we all have actually studied and learned that ADHD has various phenotypes. It affects the cognitive abilities. So there is a different kind of circuitry in terms of hyperconnectivity and hypoconnectivity between the resting state networks. But nevertheless, the diagnosis is still based on questionnaire. So the problem is the patient and the caregiver, they are reluctant to initiate the treatment, which might cause the delay in diagnosis, increased severity, comorbidity. Whereas for clinician, because there is no gold standard, it may potentially lead to overtreatment. So there lies the role of EEG. So quantitative EEG, and EEG particularly being a non-invasive marker with high temporal resolution, and we have 128 channel high density EEG. So with more than 100 channels, it has improved spatial resolution, can aid in this diagnosis. So using EEG in ADHD is not a novel thing. So it has been used previously, wherein theta beta power ratio, it has been considered as a pathognomic marker of ADHD. However, the recent meta-analysis shows that the TBR ratio can vary between different ADHD and neurotypical controls and may not be potentially a very good marker to diagnose ADHD. So our approach to ADHD research would be to potentially identify the state marker to develop therapeutics and management, and comparison with the endophenotypes or the first degree relatives or siblings in order to give reasoning about the trait marker, which reflects the predisposition to the diseases. So for that, we used a novel functional microstates analysis, which is nothing but it measures the quasi-stable topographic configuration of the scalp electric field in a spontaneous EEG over a period of time. So using the cluster-based analysis between the groups, we try to identify the microstates between the group in order to emerge out the state and the trait markers. So we found that a particular map 3, emerged out to be a state marker when we compared the ADHD children as compared to typically developing controls. And this was reflected not only in its topography, but also in the temporal parameters in terms of number of time frames, mean duration, and time coverage being higher in ADHD. Further, we dwelled upon the source analysis of that particular EEG signal during rest, and we found that in ADHD, the areas which were active, it belonged to various networks. So precuneus from DMN, the postcentral gyrus from somatosensory and attentional network, medial temporal gyrus and superior temporal gyrus from auditory processing network, and lingual gyrus from visual processing network. So here I would like to emphasize, so this is EEG during rest. So in children with ADHD, even during rest, there were areas which belong to the executive functions, apart from the resting state networks. Further, we wanted to study whether there is an effect of EEG during a performance of task. So here we used a novel visuospatial language task which had been designed in our lab, wherein there was random presentation of 60 simple words. Simple words mean which do not have vowel diacritics or matra, and 60 complex words with meaning and without meaning. So we compared the behavioral manifestations in ADHD children as compared to control, and we found that ADHD children gave subpar performance in terms of higher reaction time and poor accuracy while performing this task. So it intrigued us further to look into the cortical sources during the performance of the task. So here the red scales highlights the higher activity in the cortical sources. So, and also not only the activity was higher, but there was higher connectivity as well. So, but mind you, the performance was subpar. So for that subpar performance also, ADHD children, they had to invest more cortical sources and connectivity in order to perform in a given cognitive task. So as a state marker, visuospatial language task is able to differentiate ADHD from neurotypical controls, both in terms of the behavioral scores and EEG analysis. Further, we dwelled on taking resting EEG as a trait marker. So here we used a default mode network, which is nothing but a passive control condition, which is anti-correlated with the executive function network. So when the person performs a given task, ideally the DMN should deactivate. So as a trait marker, we compared the DMN areas amongst all these three groups: ADHD, neurotypical controls, and siblings. And we found that in case of ADHD, higher DMN activity was present during the performance of the task. So here you can all appreciate that the executive function is minimal. So this is during the performance of the task. And similar kind of profile was seen in siblings and control. So this reduced deactivation of the DMN can potentially be a trait marker in ADHD. Further, we studied the effect of trait marker using a cognitive task. I'm sure all of you are familiar with the Stroop interference task. So while performing the Stroop interference task, we found that there was an increase in the reaction time in ADHD children and their siblings as compared to control. And there was lower accuracy in siblings as compared to ADHD children and control. So when we looked into the cortical sources, we found that the microstate maps 3, which belongs to the canonical map of saliency network, emerged out as a trait marker, and even the cortical sources, they kind of pointed out that the attentional network, especially the salience ventral attention network, may be a potential feature of at-risk siblings who remain unaffected by ADHD. So to sum up, the quantitative EEG could be used as a robust tool in order to have a state marker between ADHD children and neurotypical controls, both during rest and during the performance of tasks, and as a trait marker as depicted by default mode network and performance in cognitive tasks. Stroop is what we have shown. So with that, I would like to acknowledge our lab, Stress and Cognitive Electroimaging Lab. Professor Ratna Sharma is here for giving us the forte and liberty to dwell into novel ideas. Department of Physiology for giving us the forte to perform. Department of Psychiatry for being a great collaborators. And DST and DHR for funding this study. Thank you so much. With that, I would request Dr. Renu to please. Thank you.
Okay. So here I'll be talking about the research work done by our Department of Psychiatry, mainly in the last 10 years. So one such product is like AIIMS MCTT, that is the Manualized Cognitive Training Toolkit. This manualized training toolkit has been developed for ADHD children for an age group of 6 to 11 years old children. And initially, this work was started in 2015 and as a part of intramural project. And later on, we tested the feasibility of MCTT and also tested the efficacy of the same through like one RCT study where we compared the efficacy of AIIMS manualized cognitive training toolkits against already established training modules, that is the computerized training modules like PSS, Cog Rehab, CogMed, and with treatment as usual. And we found that MCTT was having better results in comparison to the other arms. To give a brief overview about the MCTT, this particular training module is based on the past theory of intelligence. And particularly, this will target the population, ADHD population between 6 to 11 years. And here we are focusing or we are covering the 9 domains of training, where we are training children within these 9 domains, including planning, sustained attention, simultaneous processing, successive processing, working memory, language skills or verbal memory, mind-motor coordination, body balance, and visual-spatial processing. So we are having total 36 number of activities, which are play-based activities and very constructive activities. And we are having 8 difficulty level for each age group, and like for 6 to 7, 8 to 9 and all. And at the same time, we are also having 3 level of competency. So basically this module or this test battery is like, it's been developed to enhance the cognitive skills or the executive functions of the children. To have a look from the training period where we trained ADHD children. And now we have further started with the computerization of AIIMS MCTT. And with this, we have started like developing few activities. So it is an ongoing process where we are working. Okay, this is the relevant literature which we have already published. So 2 articles have been published and we one has been accepted and we are having more which are under review. Okay, another product which have been developed here with Dr. Sujata Sapati, me and Sagar sir. And this is the mobile app which is known as C Rasta. And basically this project is about the development of a bilingual mobile app which is based on the neurocognitive screening tool. And it has been, we are planning to use it for the early identification of ADHD children in an age group of 3 to 11 years, as well as with ASD children also. So here, main idea is to like to target those population which are not very like familiar with the terms. So basically, we are having the data at the 3 level, and we'll start with the non-specialist or the healthcare workers. So how will they go with the screening? So we are also having the observation tool where, with the help of the some specific material will have record the observation of the children during the assessment period. And here we are doing screening at 3 levels. At the first level, we are getting data from non-specialists like healthcare workers. Then we are having data from the clinical psychologists and the child psychologists. And at the third level, from more professionals like psychiatrists and pediatricians. So screening, this particular app will give us both screening as well as we are also planning about the severity rating. So this app has been ready for the field trial. And very soon we are going to start with the field trials. Okay. Another work which has been done here at our department, it's the development of a parent-mediated low-intensity CBT-based intervention module for neurodevelopmental disorders, including both ADHD and ASD in children, age group of 6 to 11 years. So again, this has been carried over by Dr. Sujata Satpathy, me and Sagar sir. And this is a parent training module where we are giving training to parents of ADHD children. At the same time, we are also having a separate module for the parents of ASD children. And here the target population is like from 6 to 11 years of parents of 6 to 11 years of ADHD children. So it's a 8-session module which we have developed where we are focusing on 8 different aspects. Like in first session, they were we gave them training on psychoeducation. In second, on hyperactivity and impulsivity. Third session is focusing on academic difficulty. Then fourth on inattention and cognitive skills. Then fifth on behavioral management. Then emotion regulation, social skills development. And at the same time, because parents of these children having lots of anxiety and they don't know how to manage their own stress, we are training them for their own mental health. So sessions were delivered weekly and each session lasted for 3.5 hours to 4 hours, where we made use of various kinds of modalities, like through PPT, we trained them. We were having active group discussions from the parents. Then we are also making use of, we are training them for different kind of constructive activities, which they can use at home with their children. And we are also giving them worksheets where they can continue the training at home for a period of 1 week. And then we can come back and have the feedback. So we have also done the pre and post assessment and we have got the data and we're in the process of analyzing the findings, and we're going to see the efficacy of this treatment module. So this has been basically initially pilot tested on 7 parents, and now we have tested it on a group of 28 parents of ADHD and plus ADHD plus ASD group. So this was all about the ongoing work and the things and the research projects which we have done. Now I'll request Sagar sir to continue from here.
Thank you, Dr. Renu. Now we have very tough task. As we started late, so 10 minutes, 15 minutes late. So what I will do, these are more than 35 slides, so I will try to finish in 5 minutes. So so that we have some time for this. I will quickly go through the research initiative, the research what we did, and some of the publications and so on. This was again a part of INCLINE study, and which we developed a screening tool, then clinical consensus criteria, then based on this was published in PLOS Medicine. The prevalence of these were 10 disabilities, the neurodevelopmental disabilities. 5 were of mental and behavioral disorder, like you can see speech language, ASD, intellectual disability, ADHD, and learning disorder. And you can see the prevalence around 1% based on which were done in the community. And these are the risk factors which were there, and you can see some of them are important, like low birth weight and so on. These were the modifiable risk factor and non-modifiable. Now, comorbidity also, we know that there is an important link of ADHD, externalizing disorder, or with substance use disorder. In fact, this was an important thesis, and we did work, and basically this was published also. And this is on sleep disorder. Sleep disorder, we had PhD thesis and MD thesis, and because we know that ADHD and sleep are very, very important, and we studied this. This is the MD thesis. Now, these are few publications, three or more publications which happened in sleep and ADHD. Now, this is again from Pediatric Neurology Department, Dr. Shefali, and we collaborated. And epilepsy children, how much ADHD they have. In fact, if you can see, 23% of epilepsy children have the comorbid ADHD. That is what we have mentioned, that collaboration is required. And this is also important group which we need to look at. Then these are some again important aspects of substance use disorder. There is an exacerbation of ADHD after onset of inhalant use. That's was also published. This is again a Tourette syndrome, OCD, and ADHD is a triad of neurofibromatosis. Is report which were published. Then few theses were done on psychosocial factor, that is on family. This thesis was done in 2000, almost 10 years back. Then this was on with nursing department. We developed certain modules how we can train teachers, and this was also very effective. That we can train teachers so that they can identify students in their class. And this was another study, primary school teacher, we could train them. And again, this was published also in Indian Journal of Psychological Medicine. Then many theses have been done, research on the biological factors. Now this was done with our physiology department, Dr. Deepak, on autonomic function, SLD, along with comorbid ADHD. And few publication also has come up based on this particular work. Then other than this, we also did with neurochemistry. We looked at the peripheral biomarkers, a clinical profile and peripheral biomarkers in ADHD. Again, this was also published in Asian Journal of Psychiatry. Then just recently, we had completed this study by Sumega, immunological oxidative markers and cognitive function. And you can see that there is a rise of pro-inflammatory cytokines, TNF-alpha, and so on. There are many other theses also with regard to outcome, short-term outcome of ADHD. 2009, almost 15 years ago, we did short-term outcome of ADHD. And this is the important review article from Indian perspective. This is the quality of web information on ADHD, how to take information. There are certain criteria, the quality of information, how it can be taken from the web. This is a study on outcome of ADHD, which we wish to complete later time on 2-year long-term follow-up. Then this is on the, this was one project as a Fogarty Fellowship project from US. And this was the evaluation novel neuroplasticity based training program. And we had publication on this, one on translational psychiatry with high impact journal. And then this is, we were collaborating with RBSK also. RBSK, you will know, Rashtriya Bal Swasthya Karyakram. There is a whole program, and there are 4 Ds. One of the Ds, learning, developmental delays. In that, so we had interacted, we have done a group. We had, but during the COVID time, it could not, take up. But yes, we will take up. But all the work has been done. We have developed the manual for this. These are Dr. Rachna was mentioning about Monica's thesis based on the chapter which was written in the book by Springer. Again, a CBT in ADHD. In fact, she mentioned about it. So this chapter talks about it. Then this is the important PG textbook, which is widely quoted and said to be the equivalent of Nelson book from India. And there is we also have written a chapter here. So the take-home message again is ADHD is a disabling condition, we all know by now, and significant impairment it leads to, and also not in children but also later in life. I think that's a key. That's a very important message we wish to give here. Not only to child and family, but also the caregiver. That also is important. We need to look at the burden to the caregiver. Concept and research is evolving. Again, you can see that many research is being happening in last 2 decades. A lot of research from India also has happened. From our own department, we can see that I think would be leading in the amount of research we have done in almost a decade or 2 decades. It contributes to morbidity, not only morbidity, but also mortality. I think that's a very key and very important aspect. And we wish to look at in the future now that, in fact, we have one thesis with a trauma center where we accidents and all, how it happens. So that also we'll be looking in the future. Comorbidity, we know it not only psychiatric, but also medical comorbidity. I think Dr. Bichitra presented that it is not only psychiatric, but also a lot of medical conditions, asthma, other medical conditions, metabolic, they all have a high odd ratio, you can see. And management again has to be multimodal. And Dr. Rachna, Dr. Bichitra presented that the best outcome is with and which is what we are doing in our department. So the important is to screen and intervene timely in person with ADHD. These are the acknowledgement. I think the whole list, list is endless, but I would like to, but there are many others. I think most important are not mentioned here are the children with ADHD in the family. I think ultimately, they come here with a lot of hope, and they are to be acknowledged, all of us. With this, I will end here. Thank you so much. I think, okay, we are on time. Thank you so much. Thank you.